So we can go over some fun tracings. And I want to say from the outset that you need to know these are not easy tracings. For many years, I was one of the people who wrote the board exam for the United States. And what I've tried to do is give you examples of what we would expect candidates to go through. But these are not easy ones, so please don't be dismayed if you don't get the answer right away. So let's take a look at the first unknown. Now, this is a patient who's on the left-hand side of the slide, a right bundle branch block tachycardia. I don't want you to worry for the moment about the mechanism of tachycardia. That's not the question I plan to ask you. In the middle of the tracing, we introduce a premature ventricular complex, and then you can see on the left-hand side that the rhythm is now the same, except we've lost the right bundle branch block. So what I want you to think about a little bit, and then we'll come back and discuss in more detail, is what do you think the mechanism is of why this person had a right bundle branch block? Do you think it's best explained by A, transeptal concealed conduction, B, acceleration dependency, C, retrograde conduction into the left bundle branch block, or D, electrotonic inhibition of the right bundle branch? I'm going to let you spend the next 30 seconds looking at this, and then we will go ahead and get your answers and discuss the tracing. So let's go over the tracing and then an explanation. So let's go back to the tracing, and it can't be acceleration-dependent aberrancy because the PVC, while it normalizes the QRS, does not change the tachycardia cycle length. And for those of you who are wondering, this is classic AV node reentry, but that's not the question. So it can't be acceleration dependency, or what would happen is the bundle would start again. So we know that's wrong. And the actual answer is concealed transeptal conduction into the right bundle. And what happens there is you start the tachycardia with a premature atrial complex. It goes down the left bundle after blocking the right. It comes around, it takes time, and it goes back into the right bundle. Now, we show the circuit this way, but basically this takes time to do this. And by the time it gets back, it causes more refractoriness here. So when the next beat comes through, the same thing happens because it's still blocked. When you put a PVC in, what you do is you reset everything. So the PVC comes in early and gets to this point earlier than it would have if you did this. And therefore, it basically stops this motion. And the next beat that comes down is always normal. And that's what you see here. So the correct answer here would have been answer number A. Answer is transeptal concealed conduction into the system caused the persistence of right bundle, initially described very nicely by Gordon Moe in his laboratory, and Dr. Hein Wellens showed a very nice case example to prove it in humans. So that's great. Let's go on to the next tracing. So now this one, I want the audience, before you answer, to measure very carefully. This is a patient who we're pacing the ventricle, and we put in a premature ventricular complex. So take a close look at the tracing, and I want you to be looking really at this area right here, okay? So the question I have for everybody is the following, and listen very carefully to this question. S2 confirms conduction over what? An accessory pathway, the AV node, and accessory pathway, or the AV node. So those are your three choices. And let's go back and put on the screen the tracing. Look carefully. All the answer is in the His bundle tracing right here, and I'll give you 30 seconds to think about it and put in your answers. So let's go back to the all right, so this is the slide that we talked about. Again, the question that I've asked you to address is, where does S2 confirm conduction? So this is a very important concept, and I want you to understand this, because in my experience, most of the people, at least in the United States, the candidates who take boards, really have a hard time with trying to figure out retrograde conduction over the AV node versus pathways. And let me give you some tricks on how to do this. So when you look at the pace beat here in S1, you see a typical AV nodal pattern, You could argue that it's coming up a little bit in the coronary sinus, but as we all know, this still could be an accessory pathway in the posturoseptal area, or it could still be AV node, you're not sure, or it could be both. And then what you do is you put a premator in. And what this premator does is it takes this His tracing here, and the premature beat puts the His tracing out here. And the reason for that is that when you're going up the right bundle, you suddenly block the right bundle, you go transseptal up the left bundle, and you activate the His in a retrograde manner over the left bundle. Now, when you do that, you see that the HA interval shortens here. It was 82 milliseconds here and 24 here. And that means this A cannot be coming from the AV node because this His A would have been about the same. So the septal A here must be coming over an accessory pathway. That's the only logical explanation. So the correct question here is an accessory pathway. Understand that I'm not ruling out AV node conduction at a different part of the study. The question specifically says, what do you confirm? And the only thing you've confirmed here with the premature beat is conduction over an accessory pathway. So I don't know in Brazil if they're going to try to fool you like we do here sometimes, but you won't be fooled anymore because you now know how to make this measurement. So let's move on to the next unknown tracing. In this tracing, you see you have a tachycardia that's relatively slow. There's a His, and there's retrograde activation, or maybe it's not. It could be just an atrial tach. You don't know. So what you do during tachycardia is you put in a premature atrial complex. So the PAC is put in here right on time with the His. And what I'm going to ask you now is, based on this, what is the mechanism of tachycardia? So the question would be, the mechanism of tachycardia most likely is AV reentry tachycardia, for example, over WPW, AV node reentry, an atrial tachycardia, or an accelerated junctional tachycardia. So I'm going to want you to think about that and pick one. And I'm going to go into the explanation, but we're going to give you time to think about that when you're watching this. So here's the key. This follows the rule of what I call good carpentry. Measure twice and cut once. So you must measure intervals, and these are subtle changes. So during tachycardia, you have a consistent His to His interval that is unchanged. You put in a PAC when the His has already been identified, so you know you can't affect this area, this junctional area, yet you bring in the next the His tracing. So your premature brings in the next His without affecting this one. So therefore, you cannot have a junctional tachycardia. And this is a nice paper for you all to review by Dr. Padanilam. He works with me, and this was a very nice observation he published in 2008. So let's look at the schematic. In the schematic, let's say you thought this could be just a junctional tachycardia. If you put a PAC in after the junction has already discharged its impulse, you cannot affect the next one because this area now has been refractory to anything going on. So we know the fact you brought it in rules out a junctional tachycardia. If you have a PAC occurring here, you could get into the slow pathway sooner, and by doing so, bring in the next beat. And that's exactly what this is. So this is an example of a PAC during tachycardia at a time the His is refractory that brings in the next His, and it means that you are dealing with AV node reentry. Now, there is one basically rare other possibility, just to let you know. You could argue with me that how do I know this isn't just an atrial tachycardia with conduction over a slow pathway? That's a reasonable argument. And therefore, I just bring in the next beat because I come in earlier. However, make another measurement. Measure the His to the A here and the His to the A here, and you'll see they're fixed. And if that H to A is fixed, then this has to be part of the circuit, and that rules out atrial tachycardia. So your answer is AV node reentry. Go ahead and do more ablation and cure this patient. Okay. So now let's go on to our next case. Now, this is a case of a patient in the lab, and I took out one piece of a tracing. So this is a patient who has on the left-hand side 3 wide beats, and on the right-hand side 2 narrow beats. So you're going to have to measure and take a look at it, and here is the question that I'm asking you. The findings in this figure are best described by, and we'll go back to it in a moment, supraventricular tachycardia with and without aberrancy, the combination of 2 tachycardias at the same time, a so-called double tachycardia, in this case SVT and VT, one tachycardia that starts another one, a condition I call tachycardia-induced tachycardia, or maybe it's an SVT that just has bystander pre-excitation. So we got to go back now and look carefully. So you will have had a chance to answer to put your answer in, but let me show you what you need to do. Anytime you get a complex situation like this, you need to make multiple measurements. So put your calipers, you can take any A's you want, put them on the higher A and just march them through, okay, or march through the coronary sinus leads, and you'll see they don't change. So they're not changing. So whatever's going on above the AV node is constant. Then look at your ventricle and you find out an aha moment, because while these 2 intervals are constant, this interval changes. So, and not only that, this interval here is different than this interval. So you have 2 ongoing tachycardias not speaking to each other at the same time. So even though it's a tricky slide, if you make the measurements, you will come to the conclusion that you have VT on the left, and it's occurring during the presence of an ongoing SVT. And I'm sure many of you have seen tracings like this when you're evaluating defibrillator tracings, for example. Sometimes you'll see that there's both an atrial tachycardia going on and a ventricular tachycardia. And the way you tell that is by one of them is at one rate and one's at the other. So these are tricky, but you're easy to work out as long as you make sure you make your measurements. Let's go on to the next example. Now, this is actually quite difficult, but I'm going to walk you through it. And you need to know this technique because it's not only important for taking boards, much more importantly, it's important for you to know this in the lab so that you can make the right diagnosis and cure people like this. And I'm going to make sure you understand this mechanism in a moment. So this is a wide, complex tachycardia. And during the tachycardia, on the MCS coronary sinus lead, we put in a premature beat. And then things happen. So you have to measure very carefully what's going on. So the question I have for all of you is the following. Is the mechanism of tachycardia, and I admit this is a very complex tracing, is it AV node reentry with aberrancy? Is it antidromic reentry? Is it ventricular tachycardia? Or is it an atrial tachycardia with conduction over a bystander, but the bystander is just there, it's not part of the tachycardia circuit? So again, take a look at the tracing, and you'll make your decision of what you think it is. So let me go through this one very carefully with you. This is probably one of the more complicated tracings that you will see, and it's basically a concept I want to make sure you know to do this anytime. Anytime you have a wide complex tachycardia where you're trying to make a differential of VT versus SVT and aberrancy or pre-excitation, this is the simplest and most direct way to get your answer. So this premature, here's the critical thing. You introduce the premature complex at a time when the His bundle A has already been activated. And I'll go through why that is in a moment on a schematic. But you can see that here is your atrial activity here, and we're at a point here before we've disturbed that. So this one is not affecting the His bundle A. This premature atrial beat actually brings in the ventricular beat. And you can see now 284 has become 266. And very importantly, the QRS complex is not changed at all during this premature beat. This rules out VT. So you already know VT is not part of the answer here. That's critically important. And it's this thing for all the world on a 12-lead ECG could mimic VT. And obviously, you know this isn't aberrancy. This doesn't look anything like aberrancy, but still, that's all one of the things you'd have to rule out. Now, that gives you a starting point. So you know you bring in the V. Then you have to go back and see what it does to the next A. So this V, A here, this A comes in. So think about what we've done now, and I'll show you a schematic in a moment. You put a PAC in when you didn't disturb the AV nodal activation sequence. I mean, the A there is the same. You bring in the V, and then you bring in the next A. So what does this all mean? Well, this is what you've got to know about how to diagnose anadromic reciprocating tachycardia. So in this circuit, I'd like you to follow the red one around to begin with. This was the circuit of the tachycardia that I showed you on the left. In other words, you could see you went over a left free wall pathway, you go into the ventricle, you get back into the His-Purkinje system, back through the AV node, and that's your circuit. So you want to be sure that you put your PAC at a time that you already got your retrograde A here. And that's what we do. So right around here, here's that CS catheter that I showed you, the MCS. We put a PAC in right here. This PAC cannot reset the local A, and that's the critical thing, because you can make this a lot of diagnoses if you capture this A. But the fact that we did not affect the septal A means that if this A comes in early, it cannot be due to this beat here. Now this beat goes down to the ventricle, and that's the early V we saw. But now you have to track it around and see what it does, and it comes back up here. It comes back up here, and it resets the next A. That means it's a macro reentry circuit. You've already ruled out atrial tachycardia because you did not reset the local A here. You also have ruled out aberrancy because it's not aberrant. There's no His tracing, and it's not, a His in front of the QRS. You ruled out VT. And the only tenable diagnosis is antidromic reciprocating tachycardia. And then you might ask, well, how come I know it's not AV node reentry? And that would be a very good point to raise. Realize that when you put a PAC in that brings in an accessory pathway mediated tachycardia, you break the next V that comes in is late. So I understand you started with a PAC, and I know it didn't activate the septum, but it activates the V here, and that V is early. But this V, imagine if you put a PBC in here. You didn't do this. If I put a late PBC, you know that will never, ever pre-excite the atrium during AV node reentry. So this PAC, in essence, becomes a late PVC. And a late PVC cannot cause AV node reentry to be captured. So you have one PAC confirms your diagnosis. Please remember this maneuver. You'll find it very useful, I believe, in your careers as electrophysiologists. So let's go on to this tracing. This is a simultaneous 12-lead of a patient that was sent to me for syncope. That was the reason he got sent to me. And he has this tracing, and I can tell you you can measure the PP intervals, okay? And the PP intervals are constant. And I'm going to ask you a question. I'm going to say a clinical question now. So first, that means you're going to have to figure out what's going on and then how you would treat this person. And by the way, I am sorry, I'm neglectful to say to you, I'm happy to answer questions. So please send in whatever questions you have. And even if we don't answer them as we're going forward, when we get done with all the tracings, I'll be delighted to answer your questions. So please submit whatever questions you have, and we can go over after I go through all the tracings. So now you have this patient, they have this tracing, and I'll tell you there's no change in the PR interval, and you suddenly have a P that doesn't conduct. And my question for you is, do you immediately admit this patient to the hospital for evaluation? Are you really worried? Do you say, the heck with that, I'm just going to implant a pacemaker, I've already proven Mobitz 2. do you order an exercise test? Maybe you want to see something else going on, or do you give them an event recorder? So let's go back to the tracing. I'd like you to think about that. And what I didn't show you, but what I hope you would see, is this beat. This is the clue to the entire tracing, this beat. So you're going along, and you have no conduction here, and I will tell you this meets Mobit's 2 criteria. But you have this beat. Now, this is a suddenly short PR interval, but it's not pre-excited, like some people often think. It's the identical tracing in all 12 leads, so it's not pre-excited. It's a junctional premature beat. So if you have manifest junctional premature beats, what if you had a concealed premature beat, like this, right here, okay? And we studied this person because nobody believed me, to be frank with you. I said we ought to just monitor the person, and in fact, during monitoring, this person had nothing more than probable vagal-induced syncope, and we never did anything with him. But you can understand the worry of the referring docs having seen Mobit's 2 block in their patient, and they're having syncope. The referral was absolutely right. I would have wanted a referral like this. But the people who referred him never understood about the concept of concealed his extrasystoles. So here you see the first 2 beats are normal, normal AH, normal HV, and then there's a premature his extrasystole. This his extrasystole, although it doesn't go to the ventricle and it doesn't go to the atrium, does get into the AV node. And that's where it creates its mischief, because it blocks the next A coming down. So you have normal PR, P, no conduction, normal PR. Basically a Mobit's 2 pattern. If I didn't have the junctional beats to help me out on this tracing, frankly, I would have seriously considered a pacemaker. I might have admitted them to the hospital to more evaluate them, but I would have considered a pacemaker. But when you have a junctional beat, you must consider the alternative diagnosis, and that diagnosis is what's been called pseudo Mobit's 2. It goes by different names. In other words, this is not infrahiscine block, but instead it is a physiologic event, a his concealed beat that blocks the next beat and is the cause of the so-called Mobit's 2. And in fact, this person never had anything more done because a benign form of syncope was uncovered. Let's go on to the next tracing. This tracing is being shown to you because it's a classic ECG pattern. And I just want to make sure you know what it is. You will see it somewhere in your in not just your training, in patients who are sent to you. And I just want you to know it. So take a look at the tracing. Pay particular attention. I'll show you lead 2. Look in this area right here and just study it very carefully. Okay? And the question I have for you is, what's your best guess? Because obviously you don't have a complete answer here. I mean, you need more data. So is this an atrial tachycardia, slow fast form of AV node reentry, atypical AV node reentry, or WPW reentry? Again, go back to the tracing and take a look. Okay, so you've had time to think about this. What you have to realize is there is a little P wave, very narrow, right here, equidistant between the 2 QRS complexes. Okay? So that is an ECG observation, you can see it here too, that you simply need to know. And I'll show you the intracardiacs in a moment. Not only is it here in the middle, it's narrow. So I want you to think about, how do you get a narrow P wave? And a narrow P wave means that you have to be coming from an area of the heart where there's cancellation of forces, of atrial forces. And that area is almost always in the anterior atrial septum, because that's the true septum of the atrium. As you go more posteriorly, you're really measuring an atrium, right atrium, as you know. It's not really a septum. And when you go anterior, the right and left come together. And so what you get then in people like this is 2-to-1 block below the His with classic slow-fast AV node reentry. So look at the intracardiacs here. Let's just take this beat here to show what I mean. So here is the actual initial beat coming down. So this goes A over a slow pathway V back to the A. The next one wants to go down and do the same thing, but this hiss blocks, so you don't see it, okay? So you have the A to go to the hiss, but it blocks. However, it goes back retrograde, and because of that, because you have 2-to-1 block, and this is right smack in the middle, you get a very nice, narrow, retrograde P wave, equidistant between the two QRS complexes. Again, you just need to know that is almost pathognomonic of this condition. And then you'll see during a study, almost always a PVC comes in or something like that, and that will reset the infrahissian block, and you'll go back to your classic tachycardia. Now, if I showed you this tracing, you'd all say, why is Dr. Prystowsky at a board review course showing me garden variety of AV node reentry? Well, that's why I wouldn't do that. So this is a beautiful tracing here to show 2-to-1 block on the left, same mechanism, 2-to-1 block below the hiss, so a PVC that resets the hiss system. You almost always have a couple beats of aberrancy, and then it goes back to normal. Okay, so just have to remember that EKG and how it looks. That's almost always a 100% rule. Now, let's take a look at this tracing. Along RP tachycardia, you can see that you have negative P waves in the inferior leads. You can see that the activation pattern is sort of kind of classic for coming up somewhere in the post-receptal area of the heart. And then we do a maneuver. We put a PVC in here, and it terminates tachycardia. And this is 100% a diagnostic if you make the right measurements. So my question for you is, what is your diagnosis? Atrial tachycardia, AV node reentry, or AV reentry? And I will promise you, you can make a diagnosis here. But you got to measure very carefully. And I particularly want you to look on the His bundle lead here. Everything you need to make this diagnosis is on this lead. So we'll give you a chance to answer. Okay, let's go through this. So this is AV reentry, and I will show you a table soon that goes through the diagnostic maneuvers that prove an accessory pathway is part of a circuit. Not prove it's present, but prove it's part of a circuit. So during this long RP tachycardia coming up in the septum, and I have to tell you, I don't have the rest of this case to show you, but this was a very difficult patient because this patient also had AV node reentry with a long RP. And sometimes we thought it was the AV node reentry, and then suddenly on another case, another run in the lab, we had this tachycardia, so we went in and put the PVCs, and it was that, oh my God moment, I know what I'm dealing with. And the reason is this. The hiss to hiss intervals are spot on regular, okay? You'll see this is the hiss. I know the PVC comes in early, but it does not change this hiss. This is an antegrade hiss, okay? If you have an antegrade hiss, so you know you've already conducted antegradely, and if you put a PVC in and you terminate tachycardia without an A, and you didn't go back into the AV node and you can reproduce this, you rule out atrial tachycardia because you can't stop an atrial tachycardia without getting to the atrium. You rule out AV node reentry because you stopped the tachycardia without getting into the AV node. And guess what? There's only one thing left, AV reentry. There's an old quote from Sherlock Holmes, from Arthur Conan Doyle, and I'm just going to paraphrase it. I don't remember exactly, but it's basically that once you've ruled out the impossible, no matter whatever's left, no matter how improbable, must be the truth. So just keep your wits about you. You know you've ruled out atrial tach, AV node reentry. Guess what? You only have one other option, and you're right. It's WPW reentry. So let me show you this as my final part of this presentation. There are things that you've got to know about to be able to prove that an accessory pathway is part of the circuit. First of all, VA prolongation when you get ipsilateral bundle branch block will prove it's part of the circuit. Number two, if you get prolongation of the HA interval when the HV prolongs, that also proves that the His is part of the circuit. The only supraventricular tachycardia that involves the His-Purkinje system is WPW, so that proves it's involved. If you terminate a tachycardia like we just did with a PVC that occurs when the His bundle is refractory and does not conduct to the atrium, that's another proof. And something that I didn't show you here but occurs with some of these funny long RP tachycardias, if you put a PVC when the His is refractory, but instead of terminating tachycardia, you push out the AA interval. The only way that can happen is if there's an accessory pathway present, because it can't be an atrial tach because you didn't get up the AV node, and it can't be AV node reentry because you didn't get into the AV node. So if you perturb the PP cycle length, either bringing it in or pushing it out, it proves that a pathway's there and part of the circuit. And the fifth one is just one of my own observations, that if you start tachycardia with a VA interval, and if that VA interval during your pace beat and during your tachycardia is less than 50 milliseconds, in our experience, it's always been due to AV reentry. So that's the slide deck I want you to have some fun with and to look at and hopefully learn from. I did get a question here, and I'd like to go back to it. It was in the second tracing, so let me take a moment to get back to the second tracing. Sorry, I don't want anyone to pass out if they have... Okay, so this is the second tracing. The question comes as the following. What would confirm conduction over the AV node as well as the accessory pathway? Would short HA along with a change in activation sequence? Actually, that's a wonderful question, whoever mentioned it, because this is always difficult. The truth of the matter is, what you'd have to do here, first of all, in this situation, it is not conduction in this beat over the AV node. That you know for sure. There's nothing that's going to confirm it because it isn't happening. And the reason I say that is, this is the His A, and this is the His. And this A interval here is in the same position it's always been in, which means it has to be coming from these A's. So this there's no way to confirm something that's not going to exist. I think the thing you're actually asking is, how do I know this person couldn't have AV node conduction? And that's a great question. And for there, what you have to do is to basically put in a series of PVCs that will block the pathway and see what's left. And in fact, in this patient, as we went down and brought in the prematures even more, we actually got block of the accessory pathway, and the His was here, and then we had a different activation sequence over the AV node. So this, you can never prove from this one beat. You have to do more work in the lab to show that. Thank you for the question. That's an excellent question. So we do have another question, and it really is more of a question about my experience, not so much one of the tracings. So someone wanted to know how commonly it is that you see a left atrial slow pathway connection. I think that's another terrific question. Let's take a moment to discuss the history of this. So many years ago, we would say if we saw any activation sequence coming up that was more on the left side of the heart, for example, coming up in the left posterior area, we would always call that an accessory pathway. And I'm talking about from my training days 30 years ago, 35 years ago. Somewhere along the way, and I'm not sure if he's the first person to describe it, but certainly one of the earlier ones was Dr. Peng Chen, actually one of my former trainees who has done some wonderful work in his career. And I do remember one of their studies, and again, I'm not sure it's the first, but it was a very illuminating one. He had a series of a couple patients, I don't know if it was 2 or 3, where they noticed that the breakout point was sort of in the mid-posterior left atrium. And they assumed it was a WPW, and they started mapping around there, and they found nothing. They couldn't do anything. They couldn't get the pathway. And they figured that they wondered whether maybe this was a funny AV node that had conduction along, which wasn't well recognized there, along the muscle fibers of the coronary sinus. And indeed, they did a slow pathway ablation, and they were successful. Over the years, we've seen a number of those. I've never seen any that go out as far as the left lateral portion of the heart. But as you know, what can happen is they can track along the coronary sinus atrium, and it can give you an appearance of coming up on the left side of the heart. And it can look like, for all the world, you have a left free wall pathway. That's why it's very important for all of you to understand that every case you should go through and do your maneuvers. Now, I've been in the business an awful long time, 35 years, and I can tell you in my lab, before I ever turn on RF energy, even though if it looks a classic case, I go through the maneuvers. Number one, as a teacher, I want my fellows to understand how to do the things. And number two, every now and then you get a surprise. You find a second accessory pathway or some funny conduction over the coronary sinus atrium. So before you start to ablate, always make sure you've got all your data in hand and then go ablate. So I've seen a few of these. I will be frank with you, I've not seen tons of them, and I've done somewhere close to 4,000 AV node reentry ablations. So I've had a lot of experience in that area, and I can tell you every now and then we get one of these oddball coming up on the left side. But it's really the exception to the rule. The vast majority of those do turn out to be WPW. And by the way, a maneuver I didn't show you today, another nice way to figure those out is if you have a long RP tachycardia and it seems to be coming up in that post-receptal area, maybe even slightly on the left side, what you can do is differential ventricular pacing. And what you do there is you do your pacing from the apex of the heart and then move your catheter to the post-receptal area just below the coronary sinus and repeat your pacing maneuvers. If you have a slowly conducting accessory pathway, most of the times you can capture it very nicely when you're nearer the pathway in the back of the heart, whereas at the apex you may not be able to capture it at all. So if you're not sure and the routine apical pacing isn't doing it for you, move the catheter slightly below the coronary sinus in the post-receptal area of the right ventricle and repeat your pacing maneuvers, and almost all the time you'll make a diagnosis by doing that. Thank you for the wonderful questions.